Got it?
So for the second leg of the interview, there were a few questions that we sort of talked about before that you were sort of interrupted before you could completely answer, but if that does come up in conversation, we can go more into that. But I was just thinking of asking you about something different just for a change. So I have a question just about like a memorable experience that you've had with surgery. So, whether it be good or bad, what is something you can sort of think about that's very like memorable to you?
One always remembers one's hairiest experiences, right? And
Mhm.
you know, with uh, with things that don't go well in the operating room,
Mhm.
or and also one tends to remember the times when one's been able to turn it around. I think uh, you know, the main point of operating a lot, the reason why you train for 5 years in surgery, doing repeated and multiple different operations, is you want to be really comfortable and with bad stuff as it comes up.
Mhm.
I always tell patients that we're going to get you in trouble and we're going to get you out of trouble, and it's a Uh, it's an axiom that cause bleeding with when you do an operation. You stop the bleeding. You cause physiologic upset when you do an operation, especially a big operation, and
Mhm.
then you deal with the physiologic upset. So I guess the memorable experiences are often those where there's a something a little bit unusual, and one feels like one's learned from it, or one's gotten out. So the example is a feared consequence of rectal operations, and I mean rectal, not anal operations. By rectal, I mean you're approaching from the inside of the abdomen and go down into the pelvis and doing something to the rectum, usually taking it out for cancer,
Mhm.
taking parts of it out for cancer. A feared consequence of that is getting a little bit too far posterior in your dissection and getting into presacral veins. Presacral veins are notoriously hard to deal with the bleeding from because they don't actually have a complete circle of blood vessel. The back part is on bone, and so they're once they start bleeding, they basically don't stop, and you have to figure out a way of cauterizing them or putting pressure on them. Pressure always works, but the question is, can you maintain pressure? So, we have ideas like you could put a thumbtack into it, which has actually been done, tried, published. You could put some pressure and leave something that has pressure, but then you got to get it out somehow afterwards. Um, so I guess dealing with presacral bleeding from on the few times that I've had to do it is that those are memorable experiences because you get growing experiences, right? You get in deep trouble, you focus really intensely, and uh, and then you find a way of getting out of the trouble. Um, and of course, sometimes you don't. I mean, I think everybody's path is strewn with errors and things that haven't gone well, and that those are also learning and growing experiences. One thing about surgery, which you might find interesting, I don't know if you know about this, but a very distinct feature of surgical culture
Mhm.
is that when we have a complication, a patient dies, you call that a morbidity, or a complication where the patient's damaged in any way by our operation. Mortality, so is death, and morbidity is damage. We have the Morbidity and Mortality Conference, M&M Conference.
Mhm.
And
Yeah,
M&M
I've heard
Conference, okay, so it's a feature of the surgical culture. It's
of.
gradually spreading to other fields, but it starts in surgery. And
Okay.
you get together and you talk about these things,
Mhm.
and we're critical of each other, but we're also a community, and
Mhm.
so you actually get support and criticism from your colleagues.
Mhm.
And the reason why that's so valuable is that whoever's doing the criticism is going to be criticized next, right?
Hmm.
So it's a, and that I actually find I've probably been to a couple of thousand M&M conferences over the years,
Hmm.
and I find that to be the emotional and moral highlight of my week.
Okay.
It's usually not nasty. It's usually quite supportive, and
Hmm.
we get some of these things off our chest
Hmm. Because
among
yeah,
people
when
who
you're a
don't.
surgeon, I can understand how like a lot of your actions have very like um, big consequences, and it like your actions can be life threatening or life saving. So it always helps to have that sort of support system and this like team sort of working with you. I've heard of this before, so I like volunteer at the emergency department, and
Uh-huh.
I've heard about how they have conferences there when they have like fatal, like people come in an ambulance and something happens and things don't go as planned. So they have these conferences to sort of reconvene and talk about what they could have done better, and what has happened. But I didn't realize I learned something new um, about how this like originated from like the surgical field. Yeah, and that's
Yeah,
really
I
interesting.
do think we started it, and I do think that some other folks who practice M&M conferences do it well, and
Mm-hmm.
I would bet that ER medicine would do it well because they have a similar model where there's an episode. You know, one of the problems with this model for talking about errors and bad outcomes is that you're really oftentimes in in chronic care, let's say in internal medicine or in rheumatology, something like that, you don't really very hard to distinguish patient disease from the results of your intervention.
Mm-hmm.
Whereas when the intervention is so radical, as it often is in the ER med, and it pretty much always is in surgery,
Mm-hmm.
you know, it's a very distinct time point. You've really done something to a person, preferably for their benefit. And then if there's consequences are going to occur within a reasonable time period after the event. And so you could say, anything that happens bad within a patient to a patient within 30 days of an operation is a quote unquote operative complication. No, we don't like to use that word anymore, maybe, but the same thing is true with the emergency room where the time is compressed. I think this is harder to do in some other fields, which is probably why they don't do it much or don't do it as well. It's
Mm-hmm.
just the model works well for episodic or procedural things like surgery.
That makes sense. And a follow-up question that might sort of relate to what we were talking about is just, previously you sort of talk about the rewards to surgery, about how you get like a result right away, and you're able to like, see how your actions affect the person. But what are some challenges that you might face in surgery? I guess apart from like potentially death and other like hard situations that you might face? Like, what are other challenges that sort of come like in the field of surgery, and how might you overcome it too? So,
Well, one big one is learning outside of residency.
okay. Hmm.
Let's say that you've done your residency, you're a qualified surgeon, you're out there doing the job, and then things change, right? Things change in the world of science, things change in the world of academics, things change in the world of practice. How do you keep current? You've got to make time for training. It's not going to be done for you.
Hmm.
And oftentimes, especially in private practice, time is money, and you're loath to contribute your time to something that doesn't necessarily, give you immediate results.
Hmm.
And so there is a tendency for all of us, and I don't mean just private practice, all of us, to fall behind, to get into habits, to disregard the current literature because I know better, out of my long experience, that kind of thing. And so I think keeping up, uh, what you might call keeping young, is
Hmm.
actually a big challenge when you're done with training. How do you overcome it? You force yourself to devote time. You also spend time with colleagues, and this is especially difficult if you're in a rural or a solo practice setting
Hmm.
where you really have to force yourself to be with other surgeons or other people in your field, by online communities. Most of these problems are solved by community and by talking with and getting advice from colleagues.
Hmm.
Um, People who are and surgeons tend to be individualists.
Hmm.
And that's a stereotype, but it's got a certain more than a grain of truth in it. And so the individual often has the trouble, admitting that you're wrong or admitting you need help or something like that. And and the challenge is get with others and talk things over and figure out what you need to change. Another challenge would be you cannot be in this field for any amount of time without getting sued,
Oh.
and it's very painful. I mean, I don't spend my time really thinking of myself as a humanitarian.
Mhm.
I spend my time thinking of myself as a technologist, if you will. Someone whose job is to do a really good job for the patient. But the patient is almost abstracted. And on the other hand, when patients decide that I'm a bad guy and come after me, it really turns my world upside down.
Mhm.
I have heartburn for weeks. I have trouble sleeping, and the challenge there is to remind yourself that what you're actually doing is to folks' benefit 99% of the time, and when it's not, it's erroneous. It's something that you're trying to fix, and so but there will come a time for every single proceduralist, and for that matter, emergency physician, gynecologist, whatever. There will come a time when patients decide you're the devil, or they just have a potential gain from suing you, and so then you feel really crummy, and it lasts a long time. You have to hold up that feeling of self-worth, where when it's been knocked down, you have to hold it up for a couple of years at a time, because there's no such thing as a lawsuit that lasts less than that.
Wow, I've never really considered this aspect of surgery. How I'm just curious, like how does it like usually end up like just how does it work out? You know,
How does a malpractice lawsuit work out?
like yeah. So if you're getting sued, like so do you end up paying like money to the person who sues you, or do you get out of it? Do you have sort of like in a way insurance or something to protect yourself from like these?
Well, I'm in an institutional practice where I work for the Veterans Administration,
Mhm.
and I'm on the UC San Diego faculty. So the two institutions that I do work for self-insure, which means that a lawsuit in the VA system is actually a tort claim. It's not
Mhm.
a lawsuit in the usual sense. Lawsuit in at the U is a lawsuit. Both of the institutions have their own legal folks who help protect
Mhm.
the institutions and secondarily help protect the faculty.
Mhm.
And, how does it usually end up? Almost everything always settles, right? The vast majority of lawsuits settle, and then when they settle, they their question is, has it settled for enough to put the physician in a compromised position, like do your can you keep your credentials? Can you keep your do you get listed in the National Practitioner Data Bank, which is a sort of national bad doctor list which the government maintains? Of course, they're not all bad doctors, but those, and usually the institutions then will have some sort of attribution. If they settle for a certain amount of money, how much of that money is attributed to you? Now, I've got a clean record, and that's nice. But to maintain a clean record, it takes a whole
Pressure and so.
lot of effort and a whole lot of heartache.
Mhm.
And I think I've probably gotten off easily, relatively speaking. And it's not the main part of one's work. That's why we're talking about it. We're devoting time to it. You asked what some challenges were. Um,
But
big,
I guess sure, like the rewarding, the gratifying part of your job obviously outweighs these challenges for sure.
yeah, it is actually quite a joyful profession.
Mhm.
You just feel good most of the time. And also most of the people you meet,
Mhm.
including most of the patients, are grateful and the colleagues are supportive and everything is fine most of the time.
Yes.
And when it's not fun, you really, really lean on grateful patients and supportive colleagues,
Mhm.
psychologically.
So now I'm wondering, so what sort of a person would you say is like best fit to becoming a surgeon, or do you think it's just something? Is it like a skill you develop over time? And what sort of mindset do you need to be like going into such a field? because I'm sure there are a lot of people like already considering medical school who like think about whether or not they're cut out for studying for so many years, and for surgery for sure you have like years of residency and fellowship, and just so much education, and there's self-doubt that you might come across along the way, and it's just like, who do you think is cut out for this field, or is there even such a thing? And do you think it is like just a skill that you practice, and you can improve on?
I mean, there are character traits that characterize surgeons as a group.
Mm-hmm.
Um, I think I mentioned something about the desire to do something with one's hands, the desire for earlier gratification rather than later gratification.
Mm-hmm.
You can see something, you've done it. Those are good feelings, and that tend to be reinforced by these procedural specialties.
Mm-hmm.
Um, you know, I think the person who the and there's a certain individualistic aspect to it, like I'm doing something. It's it's my hands fixing the problem or doing the thing. So that's about all. It's a pretty big tent, and the physical skills are not the main point,
Okay.
right? Almost, I think we can teach surgical skills to a lot of different people. The people who do it well
Mm-hmm.
are the people with I guess the following characteristics. It's you got to be detail oriented, fairly. We use the expression compulsive
Mm-hmm.
as a comment. She's compulsive. That's good, right? That's a comment. That's compliments. And also certain you're compelled to do it well, and you're compelled to finish it. You're compelled to pay attention to the details.
Mm-hmm.
That's one thing. And another thing is there's a kind of honesty which, and this isn't just surgery, this is all of medicine, I think.
Mm-hmm.
If you're not honest, nature will find you out and hurt you. And of course, the person it'll hurt you through is your patient. The patient will be hurt by your lack of honesty. So one thing that you just insist on among residents and among colleagues and eventually for oneself, is a kind of a complete honesty, which uh, which is sometimes hard to do, but is very much a characteristic that's needed. So sort of detail oriented, likes doing stuff with their hands, can be perfectly honest, at least most of the time, and the rest of the time can be corrected. Those are kind of baseline characteristics. It's pretty broad.
Mm-hmm.
All kinds of people can qualify.
Well, that's very interesting. Um, what are some people that you sort of work with as a surgeon? So is it because I mean obviously it has a lot to do with your thoughts and your like decision making at that time, but who are other people that you sort of have to collaborate with when you're performing a surgery, and how does that sort of play out?
The one's team. At a teaching hospital, the team is residents
Mm-hmm.
and to a lesser extent medical students. And the medical students spend more time observing, and they run through pretty quickly, and so they're not they're not core members of the team from the point of view of the operating surgeon. The residents surely are, and the
Mm-hmm.
residents are you'll work per resident for months at a time, a month at a minimum, sometimes several months. And of course, you'll work with them on a recurring basis. It's their 5-year residency program, and so you have a recurrent experience with residents. So you really get to know them very, very well, their character, their flaws, their foibles, etc. And those are the folks you work with the most closely. And then in any kind of group practice, or you have you have folks that do things like scheduling,
Mm-hmm.
and like there's a couple of nurses that I work with, and they are more institutional memory from my group than anyone except the surgeons. And even the surgeons only know their own patients, and the nurse who does the nurse case management knows pretty much everybody's patients. And so, you're working with a good nurse case manager. That person is like your helpmeet, your support, your everything. Um, so and occasionally, folks, it's rare in a big institution, but occasionally surgeons also have scrub nurses and surgical techs who work with them routinely, and in which case that person becomes your right hand.
Mhm.
Now, I've never had that, but I certainly have scrub nurses and surgical techs whom I relate to very well, work with all the time. But all the time doesn't mean all the time in the sense of a true close team, the way it is with the case manager. So, you can imagine the workflow, right? There's every patient comes to a clinic, you know, the clinic has staff you work with all the time, right? Every patient gets scheduled for an operation by the nurse case manager. Every patient gets an operation with the surgeon plus the surgical team. Every patient comes back to clinic afterwards.
Mhm.
And so anyone that you're going to see in those places that you work with routinely, they're going to feel like your helpmates and your supporters and the people that you work with. And so, it's certainly a team sport. It's certainly one in which you're a key member, not the captain necessarily, but a key member of the team. And the people that you work with closely, especially over a period of years, are going to become your close associates, whether or not they have an MD after their name.
Okay. And then going back to another question that we sort of talked about previously, you were explaining to me how your your role as like a so how your role as a professor sort of goes with like your role as a clinical surgeon, like how that all goes together. Um, so if you could like elaborate on that and sort of finish your comment on that, that would be great. And also, I was wondering what experience you sort of had with the research side of surgery and like if you've published papers, like what your experience with all of that has been, and why you've chosen to be more involved in the field of actually like performing surgeries and actually being involved in that process.
So, there are different there are different kinds of academic physicians, academic surgeons, right? You can be a research predominant academic surgeon. We'll just talk
Mm-hmm.
about general surgery here, where you have a lab and you also sort of part-time clinical, part-time research. And those people often also teach, and that's the so-called triple threat, the person who can do everything well.
Mm-hmm.
I don't claim to be that person, and I really don't do research. That is, I don't have a lab. Now, I do clinical teaching and clinical work, which is plenty. There's still time management problems when you have just two legs of the stool as opposed to the classic academic three.
Mm-hmm.
Now, because teaching and clinical work often conflict, and you have to make time for one, and you have to try and do both well.
Mm-hmm.
Now, one does in fact end up doing some research because, um, like for instance, um, I have I figure my role as a clinical teacher is also I'm a pretty experienced clinician, and I'm going to come up with some ideas which I can then put into the marketplace of ideas, and other folks can look at them and see, does that make sense? Example, when I graduated from residency program in 1995, it was uh, the HIV effective antiviral therapy had just come out, and HIV was no longer a death sentence. And this just showed up as a new thing on the landscape. How did it affect the surgeons? Well, with folks with HIV living for longer and not dying of opportunistic infections anymore, a new problem arose. The new problem was, of course, it's great, a kind of good problem to have because previously everyone was dying, and so you didn't notice this problem. But the problem was the problem of anal dysplasia.
Mm-hmm.
Uh, that is, folks would get precancerous conditions of the anus. They're living for a long time, and what do you do with the precancerous condition of the anus? My training in that consisted of seeing just a few cases of something we used to call Bowen's disease, and we used to do big operations for it. Suddenly, a flood of patients arrives at my doorstep, and all of whom have high grade dysplasia, a precancerous condition, none of whom seems sick, and I just rebel at the idea of doing big operations, and so I just came up with my own protocol of following these folks closely with physical examination, seeing when they actually needed something done.
Mhm.
You know, after a whole bunch of years, this turns into a very valuable database of the natural history of this new condition for which there was no precedent or almost no precedent. I'm not the only one doing this, but we published papers on that and
Mhm.
did. Another example, the as a fistula surgeon, because one of the things you do as a colorectal surgeon is you do anal fistula operations. You're pretty good at it after a
Mhm.
while, and then a lot of patients who have a skin disease called hidradenitis suppurativa, which causes fistula-like things in the skin, will present with an anal version of it.
Mhm.
So I pursued those fistula-like, treating rather like fistulas. And I know the textbook says you're supposed to cut it out, but it didn't make sense to me. Thought it would better cut it open. And then also carried that, to all over the patient because I'm a general surgeon, don't have to stick to the anus just because the ticket got punched for colorectal. So, I do hidradenitis operations all over the body, wherever the disease is, and doing a less invasive type approach based on fistulotomy and based on the principles that I've learned while working in my own little corner.
Mhm.
Um, those operations, which are essentially invented here, will generate some literature. They'll also generate some observations. Another observation, for instance, when you do a bunch of hidradenitis operations, you see, I've done 300 patients worth of such operations at this point. I can assemble a database. I can say, look, here's a syndrome. Here's something that you didn't think was part of the syndrome, but I think it is. And here's some numbers that suggest it is part of the syndrome. So
Mhm.
I can add to the scientific literature that in these ways, based on practice, not based on lab work.
Mhm.
I
So
do think
through
that
your experience, you just come across so many cases, um, and just together they tell a story and sort of publish what you learned.
that's right. You
Mhm.
can't publish case reports anywhere. No such thing as a published case report. But
Mhm.
if you come up with some ideas based on your cases
Mhm.
and can then apply it in the form of a study of some kind, you can still publish that.
Okay. Um, I think one thing that sort of now connects to this, so so we sort of talked about your interest, or actually, so have you ever considered going into the field of like research academia, and like is there a reason why you chose not to? Is there like a particular story or experience that you had that just like, or is it just that like you like the instant um results, so you thought that surgery and clinical work is more like valuable to you than going into research?
Yeah, and the latter is certainly true, and I don't consider that a strength of mine. I consider that a limitation.
Oh.
But if you know your limitations and work with them,
Mhm.
you can do well, right?
Mhm.
So I'm not smart enough or patient enough to do research. I've actually tried it. I spent 2 years in the lab as a surgical resident. 5 years as a clinical resident and two as a postdoc in the lab, and I was not cut out for that. Now,
Mhm.
maybe it was the wrong lab, and maybe I was not. Maybe I'm, I don't think I don't say it's not my fault. I think it is my fault. I'm not. I don't have that kind of character, and I admire and respect the people who do. I have at least a few colleagues who can really do everything. They're
Mhm.
really good in the lab and they're really good clinically and they're darn good teachers. And gosh, it would be nice to be one of them. Um, I do have my own thing. I'm pretty good at what I do.
Mhm.
I also raise a family. I have 4 children. It's a
Mhm.
there. I time management wise and also characterologically, I could not do the lab research. So, I recognized that limitation and moved on.
So, and that sort of like leads to my next question. We sort of talked about it previously, but I didn't really like get it on camera. So I want to ask you again about how you develop. So your interest in medical school, you sort of explained that you've had like family members that were in the field, and then you were introduced to it and you obviously had an interest for medicine and surgery. But I also asked you about why you were particularly interested in um, colorectal surgery, and then you started to explain that. I didn't really get it on camera. So if
Okay.
you could, yeah, go into that again.
Yeah. So, why would you want to be a colorectal surgeon?
Just
So
like, but I mean, I think when it comes down to it, like if you're sort of cutting someone open, I don't think it matters much. But it's just what are merits to the field? What did you like think was unique? Or, like why were you drawn to the idea of going into specifically that
yeah. So
specialty?
there really is a difference. Like there are some people who want from childhood to be heart surgeons, want from
Okay.
childhood to be brain surgeons. Nobody wants from childhood to be a butt surgeon, right? And it's just fundamentally unglamorous.
That's true.
However, well, first, I'll tell you how I get there in a minute, but let me tell you, the kind of people who end up in this field
Mhm.
tend to be people with decent sense of humor, people who don't take themselves extremely seriously.
Mhm.
You'll have fewer jerks
Mhm.
per capita than you
Mhm.
will in some of the more glorious fields, such as brain surgery and heart surgery.
Mhm.
And again, with enormous respect and love for the brain and heart surgeon, you will have more jerks per capita in those fields than in mine. And in fields where you're dealing with the genitals, with the anus, with things that people don't like to talk about, you
Mhm.
cannot be in this field without at least having enough people skills to get people talking about something they don't want to talk about.
Mhm.
So you do. I felt like I found my tribe to some extent, with colorectal surgeons, and outside of colorectal surgery, who do I relate to best? The urologists. They're just like, they're dealing with the genitals, and they're dealing with with stuff that people find embarrassing, and they don't want to talk about. And so the urologists tend to have a similar set of attitudes and sense of humor. Um, and gynecologists are kind of in the same category, although not exactly, because they're also obstetricians. But in any case, that's one thing. Those are the people.
Mhm.
You know, it often ends up who your role model is. And I was in general surgery residency. I did not have a plan for what to do afterwards. I was so I was working on surviving, and trying to do a pretty good job at the job I was doing at that very moment.
Mhm.
And there was a particular mentor, a young guy he was very excited about general surgery, and he was very excited about colorectal surgery. He went off to the fellowship in the middle of his faculty position, came back really excited about colorectal surgery from this, and I took notes, and I said I want to be like this guy, and
Mhm.
because he was a genuine role model right there sitting in front of me, and I could relate to him, and so I ended up trying to do something very, very similar, following his career and also doing the same fellowship he did with was very rewarding and excellent, and I felt good about it. And we haven't exactly kept in touch over the years. We did for a while, but your a mentor comes along at different stages of your life, and you can take advantage of that. Uh, and maybe it wasn't so much a mentor as just an exemplar. He was someone who clearly loved what he was doing, was
Mhm.
excited about it. It's a rare quality, right?
Mhm.
Many people get jaded after a period of years in doing almost anything, even the most excellent thing,
Mhm.
even the thing that they start out very excited about. And so seeing that energy made me feel like I'd like to do that.
So how have actually so the meeting is going to end in 4 minutes, but now I have three questions for you. Like, how have you maintained your interest in the field of surgery? I wanted to ask you sort of about like UCSC and the programs there, and I wanted to ask you like to provide just some final advice to high school students. But
Okay,
we don't have a lot of
if you want to extend past 4 minutes, that's fine with me. Um,
time.
take as long as is needed.
Okay,
And
so we might have to exit this meeting and then re-enter. If
that'd
that's
be fine.
okay.
Be
Okay.
fine. Do that right now.
Okay, cool. Thank you.